The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining me today to discuss 2021 MIPS participation for traveling eligible clinicians. My name is Bruce Mackey, and I am a regulatory analyst and project manager at Altarum Institute based in Ann Arbor, Michigan. Today, I'll be discussing how non-office-based clinicians, who we're calling traveling clinicians for the purpose of this discussion, can participate in the Merit-Based Incentive Payment System, or MIPS track of the Quality Payment Program. I'll review common barriers this group of clinicians encounter when participating in the program, along with some tips for overcoming at least some of these significant barriers. I'll touch on adjusting expectations and calculating a return on investment to ensure you're not spending more than you're earning by participating. I'll discuss performance thresholds and payment adjustments, explore some alternative participation options that may help, provide some tips on how you can add your voice to influence program changes, and finally end with some case studies of traveling clinicians we've worked with and how they've been able to participate in MIPS. First, let's start by defining what we mean by traveling clinician. Traveling clinicians are MIPS-eligible clinicians, referred to as ECs in the program, who are not primarily office or clinic-based, treating the majority or perhaps even all of their patients in nursing homes, short or long-term care facilities, rehab facilities, hospitals, and even patient homes. MIPS was designed to work well for regular clinic-based providers, which poses some significant participation barriers for this unanchored group of clinicians. Perhaps the biggest issue facing traveling clinicians participating in MIPS is the lack of access to their patients' data. While traveling clinicians sometimes have their own EHR, patient records are often maintained in the EHR of the facility or facilities in which they see patients, which is owned and maintained by a different organization. Many traveling ECs do have their own EHR technology, but it's used more for billing purposes and typically doesn't contain the full patient record. What is maintained in the clinician's technology requires double entry by the clinicians or support staff. A lack of clinically relevant measures and activities is another significant barrier facing this cohort of clinicians. While there are more than 100 quality measures available, very few of them, it turns out, are relevant to the patients and conditions traveling ECs treat. And with the complexity of their patients, often diagnosed with multiple chronic conditions, and the high cost associated with short and long-term care facilities, scoring well in the cost performance category can also be a challenge. Let's take a closer look at the barriers across each of the MIPS performance categories and tips for overcoming them, starting with the quality performance category. As I mentioned on the previous slide, many traveling clinicians find that there is a lack of clinically relevant measures to choose from. While the measures may address conditions they encounter during patient care, there are often patient population exceptions built into the measures, which negate their applicability to their patients. Or they may find that the actions needed to get measure credit are being completed by someone else involved in the patient's care. Another common issue with quality measures is measure exclusions, which may state that it cannot be applied to the frail, patients with dementia, or residents of long-term care facilities. Given the inherent issues with proper access to EHR technology, traveling clinicians are often left with little choice than to use claims-based reporting for quality measures. This reporting method offers the fewest quality measure choices, with many, if not most, of those measures being topped out or perhaps even capped at 7 points, further limiting the potential for a great quality category score. From a billing standpoint, the lack of access to the full medical record creates significant difficulties for the coder/biller, with much of that work unfortunately falling on the clinician to complete. Many quality measures can be reported through a registry, whether it's a qualified registry or a qualified clinical data registry. But the lack of access to the complete medical record via an EHR makes it impossible for the registry to interface directly to the technology to access the necessary data. Some registries allow manual data entry into a portal, but that is a very resource-intensive process, and the limited access to the facility's data creates additional challenges for registry reporting. And while it's certainly possible to do the double entry needed to create a fairly complete patient record in the clinician's own EHR, there are only a maximum total of 47 electronic clinical quality measures that even the most robust EHR can offer, with many of the EHR products only offering a handful of these ECQMs, perhaps none of them being clinically relevant. While these barriers we just covered are significant, it is still possible to score well in the quality category. One path to finding the most clinically relevant quality measures to report on is to take a look at the specialty measure sets CMS has developed. With specialty measure sets, CMS has done the work to comb through all of the various measures through the lens of many different specialties to create sublists of clinically relevant measures. It just so happens that they have created a specialty measure set for clinicians working in a skilled nursing facility. This list of 13 clinically relevant measures includes options for reporting via claims, registry, and EHR. Here we see 6 of the set listed, with the remaining 7 measures in the set listed here. You can access this specialty measure set along with additional details and measure specifications at the CMS QPP website located at www.qpp.cms.gov. As you're combing through the reportable quality measures, be sure to note each measure's exceptions and exclusions, as you may find that while you're doing the work and/or addressing the appropriate condition, the measure's specifications may cause it to not apply to your patients due to frailty, dementia, or the care facility housing the patient. This slide demonstrates exclusions for some common measures. And on the flip side, you may find it helpful to focus on the measures which actually do address a condition frequently encountered, such as dementia. There are 3 available quality measures which focus on this condition, measure numbers 282, 286, and 288. Note that while many of the quality measures are offered year after year, and you're able to continue reporting on them each year, measure specifications do sometimes change from one year to the next. So you need to ensure you're reviewing your chosen measures specifications each year to be aware of any applicable changes. The box on the right of this slide contains a link to the claims-based measures specifications and supporting documents. There are similar resources available for the other measure reporting options as well. Additionally, if you're using claims-based measure reporting, which can be complex, it's a good idea to review your explanation of benefits to ensure all T's are being crossed and all I's dotted, meaning you're getting proper credit for the work. Here we have an image taken from the 2021 Part B Claims Reporting Quick Start Guide, which provides guidance on what properly coded claims should look like, as well as some common errors that are made which prevent clinicians from getting credit for the work they're doing. Monitor your EOBs to ensure you and your staff are documenting and billing codes correctly, and use the available resources to help keep you on track. Monitoring your performance throughout the year on your chosen quality measures is also vital for ensuring you receive a decent category score. This is easier to do when reporting via a registry or EHR, which often have dashboards available to help with ongoing performance monitoring. Note that you do have some limited access to claims-based reporting data throughout the year as well, via the CMS QPP submission portal available through the login portion of the same website I mentioned previously, www.qpp.cms.gov. As you continue to code claims throughout the year, periodically log into your QPP portal to see how you're performing on your claims-based measures, making adjustments in workflows and protocols, and following up with patients as needed to improve performance. Moving on to the Improvement Activities Performance category, common barriers experienced include a relatively low number of activities appropriate for the patient populations and care settings relevant to traveling clinicians. For those activities that are available, a lack of available clinical support staff at the point of care leaves the burden of completing activities and documenting proof of implementation on clinicians. On this slide, we've curated a list of improvement activities that are pertinent to traveling clinicians and their patients. These are not the only improvement activities available to you, of course, but these are the ones that our team of MIPS advisors have selected as applicable to most practices treating patients outside the typical clinic setting. For whichever improvement activities you select, be sure to review the MIPS data validation criteria file linked at the bottom of this slide for guidance on examples of actions that would satisfy each activity and the documentation you should keep on file to prove successful implementation in case of audit. Now let's discuss the promoting interoperability category. Common barriers for this category surround the fact that generally, the traveling clinician does not have access to or control over the facility's EHR, so data on the measures cannot be abstracted and reported. Additionally, the patient population generally being served does not use computers or smartphones, so patient portal access is extremely limited. And finally, the exchange of health information would be sent and received by the facility's EHR rather than the traveling clinicians, again limiting the ability to score well in this performance category. Thankfully, CMS offers you the option to file for a PI hardship exception to avoid needing to participate in this performance category. You must go online at www.qpp.cms.gov to apply for this hardship exception, but it is automatically approved if you meet one of the 5 reasons listed here. While any of the 5 might apply to your situation, being what CMS deems a small practice, which is defined as having 15 or fewer clinicians in your tax ID, or claiming a lack of control over the availability of certified EHR technology, are likely the most appropriate ones for traveling clinicians to use. By getting this hardship exception, the 25% scoring weight for this category transfers over to the quality category, leaving the PI category worth 0% of your MIPS final score. I strongly encourage you to apply for this PI hardship exception. You have until December 31st to complete and submit it. Of all the MIPS categories, perhaps the one fraught with the most complications and the fewest available remedies is cost. By nature of the settings where traveling clinicians see patients, their patient populations are significantly more complex and in poorer health than the average patient population of a clinic-based EC, meaning they are more likely to require inpatient admission. Cost of care for these patients is unavoidably high, given that acute inpatient, short-term, and long-term stays are far more costly than typical outpatient E&M services. There are 2 global measures in the cost category: total per capita cost of care, or TPCC, and Medicare spending per beneficiary, or MSPB. Attribution has changed significantly in the last couple of years for both global measures, making it more difficult to understand and much harder to predict which patients might be attributed to you. I'm not going to discuss these measures in detail today because that would take too much time and falls outside of the scope of this presentation, but I'll try to briefly explain how to know whether these measures apply to you. For the traveling ECs, attribution primarily depends on the place of service for Part B billed claims. For total per capita cost of care, which looks at the total of Part A and Part B costs during the performance period, if you only see patients in inpatient facilities or skilled nursing facilities, you will not have patients attributed for this measure. If you see patients in their homes or in assisted living facilities that do not offer skilled nursing care, you are likely to have patients attributed. I'm going to repeat that. If you only see patients in inpatient facilities or skilled nursing facilities, you will not have patients attributed for this measure. But if you see patients in their homes or in assisted living facilities that do not offer skilled nursing care, you are likely to have patients attributed to you. For the Medicare spending per beneficiary measure, you can only have attributed patients if you see patients in acute inpatient facilities. If you do not, then you do not need to worry about this measure. If you do see patients in the inpatient setting, Your likelihood of having attributed patients depends on how frequently you bill from that setting. If you see patients there daily or weekly, you are highly likely to have attributed patients. If you see patients there infrequently, you are less likely to have attributed patients, or at least enough attributed patients to trigger a score for this measure. Although cost is a difficult category to impact, there are two proactive steps you can take to be better prepared. First, I encourage you to put in the time to understand which cost category measures might apply to you. I talked in the last slide about how to know whether the two global measures might apply. There are also 18 episode-based cost measures. However, only a handful might apply to traveling clinicians, specifically the acute condition episode-based measures. Those are listed on this slide. All of these measures will only apply to clinicians who see patients in inpatient facilities, and all require 20 attributed patients for scoring. I know the cost measures can be overwhelming, so don't hesitate to reach out to a MIPS advisor for your state if you would like help with this. Second, you should consider submitting an extreme and uncontrollable circumstances, or EUC, exception application for 2021 for the cost category due to the unpredictable and uncontrollable impact of COVID-19 on cost overall. CMS is allowing any clinicians who believe the pandemic might negatively impact their cost score and thus their MIPS final score and payment adjustment to request re-weighting for this category. The exception application is easy and does not require any burden of proof. I'll talk more about the EUC exception in a few minutes. I'm not going to sugarcoat things here. The MIPS program was designed to be a one-size-fits-all program, but it falls very short when it comes to supporting traveling clinicians. As such, and until the program changes more, you may need to adjust your expectations. If you're beating your head against the wall trying to get a positive payment adjustment, you may be wasting time and effort chasing after an impossible goal. Instead, you may choose the slightly less headache-prone goal of just making sure you have enough points to avoid or perhaps even minimize the penalty. Be careful to not spend more money than you're earning back. Your time is valuable and finite. Calculate what a Medicare payment penalty will cost you and ensure that you're not throwing good money after bad by putting so much time and effort into MIPS participation that you're actually making things worse financially. You may find that taking a minor penalty is more cost-effective than spending a bunch of time and effort to squeeze out another couple of MIPS points. And consider the impacts of individual versus group level reporting. One way over the other could make a big difference in scores and subsequent payment adjustments. Joining one of the many alternative payment models, or APMs, available could be a viable option for you as well, allowing you to take advantage of the benefits this group reporting affords. And if you join the right APM, one of those deemed an advanced APM, you may find that you're exempt from reporting on MIPS entirely. I encourage you to investigate available APMs in your area to see where you best fit in these programs. This year, CMS also launched the new direct contracting entity models, which could be an option for you to avoid having to report to MIPS. I strongly recommend you take a look at the website links on this slide and do some investigation for a good fit for you and your clinic. For this year, you must achieve a minimum MIPS final score of 60 points overall to avoid any penalty. In 2021, the maximum payment penalty is minus 9%, but that's on a sliding scale. The lower the score, the higher the penalty, up to that maximum of minus 9. And this is the final program year where CMS gets to determine the minimum score to avoid a penalty. As of next year, legislation dictates that the minimum score must be based on the mean or median of the final scores from a previous year. This means we will likely see a 2022 minimum performance threshold somewhere in the range of 70 to 85 points. And in fact, the 2022 proposed rule, out now, is calling for a minimum score of 75 points next year. That means that in 2022, participants will need to achieve scores that in prior program years were considered exceptional performance just to avoid a penalty. Note that CMS is planning a significant overhaul of the MIPS program in the next several years by implementing something they've named MIPS Value Pathways, or MVPs, which has the potential to help traveling clinicians with their program participation. If successful, CMS believes this new program framework will simplify MIPS, create a more cohesive and meaningful participation experience, improve value, reduce clinician burden, and better align with APMs to help ease the transition between the two tracks. I encourage you to read more about this significant pending program change and to even consider influencing the program to better align with your clinic by submitting an MVP candidate to CMS for consideration. This is one way you can help to create a program that works better for traveling clinicians. When all is said and done, and especially when considering the negative effects the ongoing pandemic is still causing all clinics, it could be that participating in MIPS this year just isn't possible. CMS understands this and is once again offering all clinicians the option to file an extreme and uncontrollable circumstances exception application, requesting reweighting of 1, 2, 3, or perhaps all 4 MIPS performance categories, citing COVID-19 as the reason you're unable to participate this program year. You will need to explain how the pandemic has caused you undue hardship in collecting and reporting program data. If filed, your application is likely to be automatically approved. You may choose to file this for 1, 2, 3, or even all 4 of the MIPS performance categories. Taking this exception for all 4 MIPS categories allows you to automatically get a neutral MIPS score of 60 points and no payment adjustment for this performance year. I do need to caution you, though, that you still need to be gearing up for reporting again next year. Don't let this off-the-hook exception stop you from preparing appropriately to report MIPS in 2022. With that proposed minimum threshold of 75 points for next year, avoiding a penalty gets harder every year, especially if you're not actively working to improve. So what else can you do to affect the quality payment program so that it works better for you? I have 3 additional thoughts. First, call on your state's congressional legislators to discuss the program and your ongoing struggles. The program simply does not work well for you right now, and Congress can change that. Also, as of right now, the CMS-funded support that allows us and our amazing partners to support you is ending early next year on February 15th. We know you still need our help, but to do so, Congress needs to allocate additional funds to keep things rolling. These legislators need to hear from you. Second, I encourage you to continually provide CMS feedback regarding your ongoing participation struggles. CMS is listening and uses clinician feedback to support future program changes. CMS needs to hear from you. You might consider entering comments during the annual QPP proposed rule comment period. And you can always reach out to the QPP Service Center to provide feedback as well. Lastly, there is strength in numbers, so work with your professional societies to influence program changes. You might consider working with a group such as the Society for Post-Acute and Long-Term Care Medicine to have your voice heard. As we wrap up today, we wanted to provide a few examples of how some traveling clinicians have handled MIPS reporting thus far. In this first example, we have a small primary care geriatric practice in Ohio with 3 physicians, 5 physician assistants, and 1 nurse practitioner. This group does not have any physical offices. Patients are seen in skilled nursing facilities, long-term care facilities, and assisted living facilities. The practice owns and uses an EHR for clinician notes and for MIPS quality tracking. Most patient record documentation happens in the facility's EHRs, but the providers do double entry on specific parts of the visit notes to capture data needed for patient safety, coordination internally between providers, and for MIPS. For quality, the practice reports MIPS via a registry, which is interfaced with the practice's billing software. The process for transferring clinical data between the practice EHR to a registry is a multi-step process, which involves downloading eligible patient lists in Excel from the registry for each measure, reconciling clinical data downloaded via Excel from the EHR, manually updating some clinical data as needed on the spreadsheet, and uploading the completed Excel spreadsheets to the registry. The practice manager is responsible for this process during the MIPS reporting period each year. The process is a bit time-consuming, but not as onerous as manually entering each piece of clinical data into the registry portal would be. For promoting interoperability, the practice applies for the small practice hardship exception each year. Although they have an EHR, most of the PI measures do not apply to their patient population. For improvement activities, the practice has previously attested to implementation of medication management practice improvements and annual registration in the prescription drug monitoring program. For cost, the practice applied for the EUC hardship exception in 2020. Overall, this practice has done quite well with MIPS despite the challenges they face as traveling ECs. They earned small incentives in 2017 and 2018 as exceptional performers. They scored relatively well in 2019, but did not earn an incentive. Our next case study is for a small practice with only one clinician in internal medicine. The office also has an RN and a scribe to help with the administration as the clinician sees over 800 patients monthly. Patients are seen in 13 different nursing facilities and hospitals across the state. To combat the lack of access to patient records, they write their own notes during each patient visit. The scribe then uploads the notes to the clinician's EHR. This has been the practice's preferred method of MIPS reporting for 2017 and 2018. They were exempt from reporting in 2019. Our final example is a small multi-specialty group with 7 physical medicine and rehab doctors and 1 neurologist. They have no physical office. Patients are seen in skilled nursing, long-term care, and subacute care facilities, step-down units, and inpatient rehabs. The practice has their own EHR, Advanced Document Management, an Allscripts product. For quality, the clinic reports via claims, reporting the required 20 case minimum for most measures, although doing this causes them to fail to meet the data completeness threshold, so they only receive 3 points per measure. For promoting interoperability, the clinic applies for the small practice PI exception each year. They attest to their improvement activities manually via the QPP data submission portal and earn full IA category points. In the cost category, they actually score fairly well each year. So far, the practice has avoided a penalty each year and earned a small incentive in program years 2017 and 2018. They applied and were approved for an EUC exception for just the quality category in 2020 and are likely to do the same again in 2021. And unfortunately, they're not expecting to meet the minimum threshold to avoid a penalty in 2022. And barring any significant program changes, are preparing to take a penalty in subsequent years. Okay, just a few more slides for you as we wrap up. Here I've provided a plethora of resources for you regarding different aspects of MIPS reporting and other topics I've touched on in this presentation. I hope these are beneficial to you. Also, please note that you're not on your own when it comes to MIPS reporting. There is no cost assistance available to you within your state. Please go to www.qppresourcecenter.org and click Join Now. There you will find a wealth of additional resources and also phone numbers for your individual state where you can call and talk to a live QPP advisor for assistance as needed. Don't struggle on your own. We're here to help ensure you have everything you need to be successful in reporting MIPS this year. With that, I open the floor to any questions the attendees may have. And if you have additional questions following this broadcast, don't hesitate to reach out through the contact information on this slide. Thank you so much for attending today. I hope you found it helpful. Okay, let's get to your questions.